We're going to take about 5 minutes and talk about nothing but tidal volume. The subject's that important that it warrants its own discussion. So tidal volume, as we all know, along with respiratory rate, determines our minute ventilation. We all know that minute ventilation determines how much carbon dioxide we actually get out of our bodies. Going up on tidal volume or going up on respiratory rate will decrease your CO2 levels. Tidal volume is actually the most efficient way to get CO2 levels down. So because of this, we used to go to some pretty high tidal volumes. This all changed in 2000 with publication of the ARDS trial, which showed that these high tidal volumes were actually quite harmful to our patients. Since that time, there's been a push to get tidal volumes down and employ what's called protective lung ventilation techniques to improve our patients' outcomes. So how are we doing with that? Not great. There's a lot of evidence out there showing that we're not doing a good job adhering to these protective lung ventilation techniques. This study in particular looked at ED patients and showed we were only about 55% compliant with protective lung ventilation techniques. And in our ARDS population, the population that's at most risk for further lung damage, we were only 47% compliant with protective lung ventilation tidal volumes. So we definitely need to do better. One mistake we make is a lot of us have this preset tidal volume in our brain. And anytime a patient comes in, we say, oh, well, this is a female patient. Female patients are usually about a 450 tidal volume. This is not the case. We're actually probably getting close on our taller, more slender population. But on our shorter, more portly population, we're doing a terrible job estimating their tidal volumes. We frequently overestimate how much volume they need, and we're doing a lot of damage to their lungs. Just because the patient's fatter doesn't mean their lungs are bigger. So how can we do a better job? Well, first of all, measure your patient. You need to get an accurate height on their patient because all this is based on ideal body weight. And to calculate that, you need to know how tall your patient is. We're not carnival workers. We're not good at guessing. Get a tape measure, measure your patient. Once you've measured your patient, you can put their height into an ideal body weight calculator. I like this one on MD Calc because not only does it give you your ideal body weight, but you can put your target tidal volume as far as mLs per kg, and it will spit out a tidal volume for you as well. Here's the way that I like to do it. Here's a table we use in our shop. It has the patient's height in inches and relates that to their ideal body weight, their tidal volume at 6 mLs per kg, and their tidal volume at 8 mLs per kg. That way, as soon as you've measured your patient, you can look at this table and you immediately know where your tidal volume needs to be under. Again, we made it this size so they can be printed off and placed on the back of an ID badge. And very quickly, you can get your max tidal volume for your patient based on their height. Now you'll notice we have 6 mLs and 8 mLs per kg. You should always keep your patient's tidal volume under 8 mLs per kg. If they have ARDS, you need to get that tidal volume under 6 mLs per kg. So the question becomes, how do we know if our patient that we've just intubated is an ARDS? So the definition of ARDS is set forth by the Berlin criteria. Here's a brief summary of those. This takes some exploration. It takes some radiology studies. It takes some history to determine if the patient actually is an ARDS. I have a quick screening tool that I use to know if I need to go down this pathway, and that's to look at the PaO2 to FiO2 ratio very quickly. How do I do this without a blood gas? Well, PaO2 to FiO2, I can estimate the PaO2 based on a SAT of 90. I know that a SAT of 90 is roughly equivalent to a PaO2 of 60. So if my patient's SAT is right at 90, I assume the PaO2 is 60. And then my FiO2, I try to always start at a 30% FiO2. So when I plug that into the equation, 30% is equal to 0.3. It gives me a PF ratio of 200. So if my patient cannot maintain a SAT of 90% on a 30% FiO2, then my PF ratio is below 200. And if I am in ARDS, at this point, I'm in at least moderate ARDS, and I really need to get that tidal volume down. So let's look at an ABG very quickly. I've got this patient that's acidotic, clearly a respiratory acidosis based on the CO2 level. How can I make this ABG look better? Well, always think about going up on respiratory rate. If you go on high respiratory rates around 30, you're going to need your RT to help you set the vent so that the patient won't be bucking at that high of a rate. Think about permissive hypercapnia. You can let your pH go down to 7.25 or even 7.15 if your patient's hemodynamically stable rather than hurting the lungs. In really bad off patients, think about ECMO. Go ahead and take that CO2 out through a line in the patient's vein rather than by damaging the lungs. And then finally, as a last resort, if you have to, go up on tidal volume. To quickly review, always get an accurate height on your patient. Once you get that accurate height on your patient, find your max tidal volume. Always start below 8 mLs per kg of ideal body weight. And if you can't saturate your patient at 90% on a 30% FiO2, consider ARDS, and consider dropping your tidal volume to 6 mLs per kg. This has been a discussion of tidal volume in about 5 minutes.